Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in. Today we're going to be discussing cardiac emergencies. This is a very important topic that has many different layers to it. Afterwards, we'll discuss some multiple choice questions for review. Let's get started with our lecture brought to you by Lane, one of our content creators.
Hi, and thank you for joining us for today's lecture. We'll be going over cardiac emergencies. To start, what is a cardiac emergency? A cardiac emergency is some level of dysfunction of the cardiovascular system, which includes the heart, pulmonary circulation, and systemic circulation. The dysfunction of the cardiovascular system, however, can affect multiple body systems due to the lack of blood flow and oxygen and nutrients to those organs, which can present with varying levels of signs and symptoms, including altered mental status, shortness of breath, syncope, nausea and vomiting, musculoskeletal weakness, abdominal pain, and indigestion. With cardiac emergencies, there is a variety of different cardiovascular related issues that can arise that we may be called for. These can include cardiac chest pain, hypertensive crisis, cardiopulmonary arrest, or cardiac arrest, dysrhythmias, and heart failure. Common complaints that may arise can include chest pain, difficulty breathing, altered mental status, dizziness, weakness, syncope, and complaints upon exertion. So when we talk about cardiac emergencies, why is cardiac health so important? Cardiac health is so important because heart disease is one of the leading killers of people or leading cause of deaths. When we talk about cardiac emergencies, why is cardiac health so important? Cardiac health is so important because heart disease is one of the leading causes of death in the United States. With that, over 650,000 people die each year due to heart disease. That's 1 in every 4 deaths, as well as 1 heart disease death occurring every 36 seconds. With that being said, there's 18.2 million Americans 20 years and older who have some varying level of coronary artery disease, as well as there being 805,000 heart attacks occurring every year. That means there's 1 heart attack every 40 seconds. So why is cardiac health so important, and why is it such a concern? Well, the saying, time is muscle, time is heart, is because with damage to the heart and damage to the heart muscle, that means that the heart may not be able to function properly after that damage has occurred. With cardiac health, we talk about cardiac arrest. Cardiac arrest is something that everyone is very familiar with, whether you're in healthcare or not. We know on average that 356,000 Americans will die of cardiac arrest each year. That's about 1,000 sudden cardiac arrest-related deaths every day. So with that, as we know, just over 50% of arrests are witnessed by a layperson or EMS, and survival to discharge with care provided by EMS being only 10.4%, and only 8.4% of them having good neurological outcomes as well. This is so important because cardiovascular-related issues and underlying medical issues are becoming more prevalent in healthcare, with heart disease being the number 1 cause of deaths, followed by cancer and unintentional accidents. Cardiovascular related issues could be attributing cause of cardiac arrest, as well as all the other underlying medical issues that could be arising with the cardiovascular health being a main issue. So why are there so many deaths related to cardiovascular health? There's lots of individuals throughout the United States who have predisposed factors to cardiovascular related issues or have other health conditions that are affecting it. With that, we can see there is some risk factors for cardiovascular health. Some of these risk factors can include some congenital issues, which can include a family history of heart disease, or some birth defects or congenital heart defects that you might have gotten from birth, as well as some developed kind of cardiovascular health related issues throughout life, which can include an inactive lifestyle or an unhealthy diet, smoking, overweight or obesity, medical conditions like diabetes, hypertension, blood clots, strokes, and AFib, or known as atrial fibrillation, and excessive alcohol consumption. All of these can lead to an increased risk of heart disease, as well as cardiovascular related health issues, as well as potential of having cardiac emergencies due to these congenital or developed issues throughout their life. Before we get into some cardiac emergencies, we'll do a brief anatomy review. We'll start with the heart. We know that the heart's main goal is to receive deoxygenated blood from the body via the inferior and superior vena cava, send it to the lungs to reoxygenate the red blood cells within it. Then the blood is received back into the heart from the lungs with oxygenated blood, and then the heart will then send it throughout the body. We know that one important factor of the heart is the myocardium, which is the heart muscle. The heart muscle is very, very important for the body's health because without a good functioning heart muscle, issues can arise throughout the body. We know that the heart muscle is a very specific type of muscle because the cells within it have their own ability to produce electrical stimulation to cause myocardial contractions throughout the heart, as well as these cells do not have the ability to regenerate like other cells throughout our body might be able to, like skin cells maybe have the ability to regenerate. Myocardial cells do not regenerate, so once the tissues or the cells have lacked nutrients or oxygen, those cells will die and they will not be able to regenerate. We consider the right side of the heart to be considered the pulmonary circulation part and the left side to be considered the systemic or full body circulation. The right side of the heart will receive the deoxygenated blood like listed, and it will pump the blood to the lungs or into pulmonary circulation where that oxygen can be rebounded onto the red blood cells and waste products and carbon dioxide can be released into the lungs and exhaled through our body. Once that has happened, the left side of the heart will receive that blood from the lungs and then pump it to the rest of the body. The left ventricle or the left chamber of the heart, which we'll discuss further in a second, is why it is so important to have adequate function of this part. With the heart, it consists of 4 chambers. We have 2 atria, which are upper chambers or receiving chambers, and 2 ventricles, which are lower chambers or sending chambers. We talked about the left ventricle being very important because it's a sending portion. The left ventricle will send oxygenated blood throughout the body. If the left ventricle lacks ability to pump properly, this can cause issues with the body perfusing properly and receiving oxygen and nutrients that it needs, as well as some other issues with heart failure that can develop within the heart and the lungs and throughout the rest of the body, which will be discussed later. The heart itself has 4 valves that prevent backflow of blood. These valves are known as the tricuspid, which is located between the right atria and the right ventricle, the pulmonary valve, which is located between the right ventricle and into pulmonary circulation, the mitral or the bicuspid valve, which is located between the left atrium and the left ventricle, and the aortic valve, which is located between the left ventricle and into the aorta. Without the heart or heart function, the body will be unable to maintain its abilities and ischemic tissue death will occur not only to the heart but to the rest of the body. As we talk about the heart has to have a way to get blood to it to supply its muscle and its tissues and cells with oxygen and nutrients. This is where coronary arteries come in. Coronary arteries deliver blood flow to different portions of the heart. As we can see in the image to the right, we can see that blood flow is fed to the coronary arteries by a starting portion of the ascending aorta, and then coronary veins will take blood back to the right atrium where it will be reoxygenated throughout the heart. Major arteries for coronary arteries can include the right coronary artery, the left coronary artery, the left anterior descending artery, and the circumflex. We know that the left coronary artery does divide into the left anterior descending and the circumflex artery. If any of these arteries become occluded by plaque or clots, blood flow will be decreased or completely blocked, resulting in tissue death or ischemia like we had talked about initially with those myocardial cells dying. As we talk about the electrical system of the heart, and we talked about each specific area, they each have important parts that play a factor into the heart's contractions. The sinoatrial node, or the SA node, is the main pacemaker of the heart that starts the impulse in the atria, causing atrial depolarization to follow, which will then result in the atria contracting and pumping blood to the ventricles. This signal then sends further to the AV node, and the SA node is known to be the pacemaker because it sets the heart rate average between 60 to 100 beats per minute. The signal then goes down to the atrioventricular node, or the AV node, where the signal will be slowed down for a very short period of time before the impulse continues down the path. This allows for the atria to contract fully without ventricular contraction occurring simultaneously, so that the atria contract to fill the ventricles, and then the ventricles can contract after. Bundle of His receives from the AV node and sends the signal down to either the left or right pathway. The left or right pathway are known as the left and right bundle branches, which are the pathway to each ventricle, the left or the right ventricle. The Purkinje fibers are special fibers within the ventricle that allow for ventricular contraction. So the Purkinje fibers will then receive the electrical impulse, and then it will cause depolarization of the ventricles, which will then result in the ventricles contracting and pumping blood. we talked about blood going into the lungs to be reoxygenated. This is called pulmonary circulation. Pulmonary circulation involves blood coming from the right side of the heart, going through the pulmonary artery into the lungs, where this blood will then be reoxygenated. The deoxygenated blood from the right ventricle going through the pulmonary arteries will then be met into these alveolar capillary membranes, which allow for byproducts of cellular metabolism and oxygen to pass across this thin membrane by diffusion. With this, diffusion will occur because particles will move from an area of high concentration to an area of low concentration. Examples of this are carbon dioxide in the blood is higher than carbon dioxide in the lungs, which then the amounts of carbon dioxide will then pass across the membrane into the alveoli. Oxygen levels are higher in the lungs than in the red blood cells and in the blood, so oxygen in the alveoli will then diffuse across the membrane into the blood to bind to the red blood cells, or specifically to the hemoglobin. Blood then goes through pulmonary veins to fill the left atria with oxygenated blood so that it is ready for the body to use. On the other side, or the opposite of pulmonary circulation, we have systemic circulation. Systemic circulation is doing the same type of function as pulmonary circulation. However, pulmonary circulation has deoxygenated blood and will be sending reoxygenated blood to the part where systemic circulation will be sending oxygenated blood, or that reoxygenated blood, to the rest of the body, and then it will then return with deoxygenated blood to the right side of the heart. The image over on the right, as you can see, will kind of show the blood flow throughout the body. With this, oxygenated blood from the left ventricle is pumped out into the aerator to be sent through the body. The oxygenated blood will be sent throughout the body, ultimately coming to arterioles into capillaries, where oxygen is let off of the red blood cells and is able to diffuse across the membranes for cells and tissues to use. Byproducts of cellular metabolism are diffused across the membranes back into the capillaries, where the venules and veins will take the byproducts and deoxygenated blood back to the heart to be released and to let off. The flow path, for example, can be listed below, where blood flow starts in the heart. Arteries always take blood away from the heart, so the arteries and arterioles will go from there. The arterioles are the smaller portions of the arteries, where arterioles will make capillaries, where the diffusion will occur due to the thin layered cell membranes. Capillaries will then go to venules, which are the smaller types of veins from the capillaries. And then veins will take the blood back to the heart. Again, remember that arteries take blood away from the heart and veins take blood back to the heart. There is no change whether it has carbon dioxide or has oxygen as far as relations to deoxygenated and oxygenated blood. The image onto the right will show that with the pulmonary artery, it is blue, meaning that it has no oxygen in it or little oxygen in it. And again, it's going to the lungs, going away from the heart. And then the pulmonary vein, on the other hand, is red because it has oxygen, brings blood back to the heart. But if you look at the systemic circulation, it's the opposite. The aorta, or the arteries, have red blood, again, which has the oxygenated blood in it. But again, it's going away from the heart, making it an artery. And then on the other side, the veins are blue, but have deoxygenated blood in them, and they are going back to the heart. So always remember, arteries go away from the heart, veins go towards the heart. Now, with a little brief overview of anatomy, we can dig into cardiac emergencies. One common type of cardiac emergency that we will see is the considered chest pain or cardiac chest pain. This chest pain is causing from some varying level of chest wall discomfort. Sometimes true cardiac complaints related to myocardial ischemia or lack of blood flow to the tissue result in the symptoms that the patient is feeling. Complaints can be related to exertion or physical activity, as well as can be onset at rest with or without stress as well. The discomfort that the patient may feel may last for varying periods of time, as well as it can come on again at rest or not at rest, and it may be relieved with rest or without rest. Complaints may be minor, with little to no distress the patient is presenting in. However, patients can present in severe discomfort, grossly diaphoretic, and present in obvious distress in some situations. So the question may arise is, how do you know if it is truly cardiac related? In some cases, you may not really know. Patient presentation, signs and symptoms, complaints, history, and assessment will help determine your potential causes. A thorough history and assessment may help guide possible causes to related or non-related to cardiovascular system. You may realize or note other symptoms that may be causing cardiac or chest wall discomfort that may not be related to the cardiovascular system. Angina pectoris is a condition that is a lack of blood flow to the myocardium, resulting in discomfort commonly caused by underlying cardiovascular disease and/or coronary artery disease. Angina pectoris is commonly referred to as stable angina due to its ability to be relieved by medications and/or rest. Onset with angina is typically related to a fixed frequency or cause. With this, typically angina pectoris episodes or stable angina episodes come on with physical exertion, stress, anxiety, strong emotions, and typically the onset is not at rest or with minimal to no exertion in some cases. Symptoms may resolve prior to EMS arrival due to the usage of medications or due to the patient resting, relieving the symptoms. Even a single episode of angina can be a precursor to a myocardial infarction, so it's always important to inform patients that regardless of their level of chest pain relief that they've had, they still should seek advanced medical care, especially with or without history of cardiovascular related issues. A myocardial infarction, or better known as a heart attack, results in a complete occlusion of blood flow through a coronary artery. So remember, those coronary arteries will be feeding the heart with blood, or the blood flow to the heart muscle and the heart structures. With this, it results in a varying level of chest pain, shortness of breath, weakness, potentially a feeling of impending doom or feeling as if they're going to die, as well as lethargy or altered mental status. The myocardial infarction can be caused by plaque breakage from a vessel wall or blood clot developing and either becoming lodged within a coronary artery or blocking blood flow past a certain point. Nitrates may result in some relief in pain due to the passage of blood flow to affected areas. However, we need to remember that myocardial infarctions or heart attacks sometimes can present atypical or without chest pain or without some of those other related symptoms, which can be common in women. Some atypical symptoms that may arise can include back pain, epigastric pain, severe indigestion, abdominal pain, and unexplained weakness or altered mental state. If a myocardial infarction is untreated, condition will progress, causing extensive myocardial-related death and will lead to fatal cardiac arrhythmias, ultimately resulting in death. Myocardial infarctions are a life-threatening emergency and need to be transported emergently to a capable facility. One thing talked about a lot in the field of healthcare now is the term ACS, or acute coronary syndrome. What is this ACS exactly? Acute coronary syndrome is an umbrella term for sudden occlusion or stoppage of blood flow to the heart, which with this, it results in myocardial cell death if the occlusion remains in place, which then may result in death as an outcome of it. Again, just like a myocardial infarction, this is considered to be a life-threatening emergency, and patients need to be considered to be emergent patients and transported to the nearest capable facility. Better patient outcomes will occur with quick detection as well as cardiac catheterization. This ACS, or acute coronary syndrome, is just another catch-all term for a myocardial infarction or unstable angina. Unstable angina is considered angina that is unrelieved by rest or is unrelieved by medications. With this ACS, severe complete blockage will commonly have no relief in pain, discomfort with medications or at rest, and ACS again needs to be considered with any patient who presents with chest pain. So with cardiac emergencies, we may have patients who have chest pain. However, the chest pain may not be related to the cardiovascular system. We can have these chest pain imitators. There's a variety of conditions that can mimic cardiac chest pain or cause chest wall pain that may or may not be related to the cardiovascular system. However, EMS may not be able to determine if the root cause of the symptoms is related to the cardiovascular system, so it's important to always have a high index of suspicion. ALS providers will be able to interpret 12-lead EKGs to see if there's any ischemia or infarct present. Ischemia is related to lack of blood flow to the tissues or lack of blood flow to the heart in this case, which can cause some of the symptoms. And infarction is related to tissue death or death of tissues because of lack of blood flow nutrients for a period of time. As well as ALS providers being able to interpret 12 leads, emergency departments will also be able to interpret 12-lead EKGs, as well as have capability to potentially having cardiologists within the facility to interpret those 12-lead EKGs. The emergency department will be able to also test for troponin levels, with troponin levels being a cardiac enzyme that, if elevated, may indicate cardiac ischemia and infarction is present. It's always important to obtain a thorough history and complete assessment to look for potential imitator symptoms, including change in pain with breathing, cough, chest wall trauma, no change in pain with nitrate treatment, similarity in pain with other medical conditions. However, some of these symptoms can also be present with cardiovascular related chest pain. So it's always important to err on the side of caution, and again, always have a high index of suspicion of it being related to an acute coronary syndrome related event. Some examples of some chest pain mimics are listed here in the image below. Some other types of cardiac emergencies we might run into or be called for can include a hypertensive crisis. Hypertension is referring to high blood pressure or high BP. Typically, we consider hypertension to be a systolic blood pressure greater than 140 millimeters of mercury, with the systolic being the top number, and the diastolic blood pressure being greater than 90 millimeters of mercury, which is the bottom number. Severe hypertension or a hypertensive crisis is considered when we have either a systolic blood pressure greater than 180 millimeters of mercury or a diastolic blood pressure greater than 120 millimeters of mercury. Patients with hypertension or hypertensive crisis can be at risk, especially with underlying medical conditions of having life-threatening issues, if their blood pressure remains persistent at elevated levels without treatment or a decrease in the blood pressure does not occur. Some issues that can arise can include ischemic or hemorrhagic strokes, myocardial ischemia or infarction, rupture of other major vessels as well, including thoracic or abdominal aorta, as well as the aortic arch being ruptured. With hypertensive crisis, patients may or may not have symptoms and may not even know that their blood pressure is elevated or have an ability to obtain a reading at home. Some common symptoms that patients may have can include severe headaches, blurred vision, tinnitus, which is ringing in ears, persistent non-traumatic nosebleeds, dizziness, lightheadedness, nausea and vomiting, anxiety, dyspnea, or difficulty breathing, and chest pain. Now, just remember that some patients may not have symptoms, so they may have no clue that their blood pressure is actually elevated in a severely life-threatening level. So symptoms may or may not be present. However, when we're called for these symptoms, hypertensive crisis should always be considered. Some patients may have stroke-like symptoms due to the hypertension as well, due to lack of blood flow to the brain. Some other symptoms that may arise can include altered mental status, blurred vision, difficulty speaking or walking, and a severe headache. Elevated blood pressure may be due to a separate medical emergency as well, including a stroke, an acute myocardial infarction, heart or kidney failure, convulsions in pregnant patients known as eclampsia, or potentially missing doses of antihypertensive medications. Another type of cardiac emergency we may run into are dysrhythmias or arrhythmias. This refers to some type of irregularity with the rate or the rhythm of the heartbeat. The rate can either be too fast or too slow, referring to tachycardia or bradycardia. And if the cause is not corrected, patient may progress into cardiac arrest over time, which can be present within minutes to hours or even days in some cases. Patients may or may not exhibit symptoms, so they could be a stable patient with minimal symptoms and stable vital signs, or an unstable patient with severe or more symptoms and unstable vital signs. Some symptoms patients may exhibit can include altered mental status, chest pain, shortness of breath, nausea or vomiting, hypotension, signs and symptoms of shock, acute heart failure, weakness, dizziness, syncope, and unconsciousness. Dysrhythmias may be related to underlying history or related to patients' medications that they're taking, although they may be caused by life-threatening conditions as well. Some history of some irregularities with the heart rate or rhythm can include atrial fibrillation or atrial flutter, SVT, which is known as supraventricular tachycardia, Wolff-Parkinson's-White, or other accessory pathway arrhythmias. So medications that may play a factor in it can include beta blockers, which are medications ending in OL, or LOL, metoprolol, and atenolol are examples, which may present with bradycardia. They may be missing medications like dysrhythmic medications like amiodarone, diltiazem, verapamil, in relation to their tachyarrhythmia or their tachycardia episode that they're having, which could be atrial fibrillation or atrial flutter with a rapid ventricular response, or even ventricular tachycardia, for examples. Medical conditions that may be causing the symptoms may be due to a myocardial infarction, new onset atrial fibrillation, sudden cardiac arrest, or potentially electrocution as well. Heart failure is another type of medical emergency or cardiac emergency we will run into. Heart failure is due to the lack of the heart's ability to pump blood efficiently. This can be due to an acute or chronic issue. Typically, acute heart failure is due to lack of blood flow to the heart, with the heart not being able to pump efficiently anymore due to damage and death potentially, or ischemia of the tissues. Symptoms that may arise from it can include altered mental status, severe weakness, diaphoresis, chest pain, dyspnea, hypotension, fever, and orthopnea. The exact cause of the acute heart failure can be from a variety of issues as well, including an active acute myocardial infarction, failure of the heart valves, cardiac arrhythmias, infection of the heart, or a pulmonary embolism. Chronic heart failure, or also known as congestive heart failure, is caused by damage to the heart from things like acute myocardial infarction, diabetes, coronary artery disease, and hypertension. Typically, like I said, with acute heart failure, it's normally due at an acute time, so symptoms develop in a period of time and there are new symptoms. Chronic or congestive heart failure typically results in symptoms that develop over a period of time due to the heart's lack ability to pump because of damage to it or damage to its structures. Heart failure can affect either the left or right side of the heart as well as both sides, and with whichever side it is affecting or both affect the heart's ability within the contraction cycle or the contraction of the heart. Left-sided heart failure commonly results in backup of blood or fluid in the lungs known as pulmonary edema, and right-sided heart failure commonly results in backup of fluid or blood within the peripheral portions of the body known as peripheral edema. Signs and symptoms of heart failure can include pulmonary edema, dyspnea, productive cough with pink frothy mucus or sputum, peripheral edema, fatigue, weight gain, pulmonary edema, weakness with normal baseline activities, so that could be walking, getting up, or putting on clothes. During assessment and history, you should look for pulmonary edema, which could be crackles or rails within their lung sounds, as well as peripheral edema, which could be in the legs, ankles, and feet. History of congestive heart failure or usage of diuretic medications to help guide your treatment and assessments of these patients. Diuretic medications can include Lasix, furosemide, hydrochlorothiazide, and spironolactone. And the last cardiac emergency we will talk about today is referring to cardiac arrest. So specifically, in summarized terms, cardiac arrest is a sudden stoppage of the heart resulting in loss of consciousness, breathing, and heart function. It is also known as cardiopulmonary arrest, and typically we are able to tell what it is by the absence of palpable pulses with an unconscious patient. So commonly, cardiac arrest is caused by cardiac arrhythmias like VFib or pulseless VTach, causing a lack of blood flow throughout the body. So typically, things go hand in hand sometimes. The short summarized way, like I said, is just an absence or stoppage of the heart. There's lots of different things that can cause a cardiac arrest, which we will talk about here in a sec. But typically with this arrhythmias that can occur, that commonly cause it, with there's arrhythmia, we get a lack of blood flow due to the heart not pumping effectively, which a lack of blood flow to the brain means the brain will become ischemic, resulting in loss of consciousness and absence of breathing. With no blood flow to the heart will become irritated, causing these arrhythmias potentially, or worsened arrhythmias, and ultimately with no oxygen for prolonged periods of time, all heart function will subside, which results in asystole, which means there's no mechanical contraction of the heart as well as any electrical contraction of the heart. Same with the brain. If the brain doesn't receive oxygen for a period of time, there will be irreversible brain death that can occur. Causes of cardiac arrest, again, can vary. As you can see, cardiovascular issues, electrolyte imbalances, metabolic issues, trauma, respiratory compromise or issues, electrocution. There's a reference called the H's and T's, which help determine reversible causes of cardiac arrest, which have multiple different reasonings of it. We can have situations with hypothermia, hypovolemia, which is lack of fluid volume. We can have hypothermia, we can have hypoglycemia, hypokalemia. The list goes on. There's T's we can talk about too, but the whole point of those H's and T's that we talk about, it's commonly talked about with ALS providers, or things that we can treat or reverse, in the EMS field, but also in the hospital. So there's certain things EMS might not be able to treat or reverse, but the hospital will be able to. So those are some reversible things to think about. Those are things that we aren't going to discuss in this today, but in further lectures you might see or might learn a little bit more about it. Now, as we finish up with talking about types of cardiac emergencies, we can start digging into our assessment of these emergencies. And typically with most assessments, as we know, we start with our ABCs, mentation, patient complaints. So complaints patients might complain about with cardiac emergencies are going to vary based on the underlying cause or what the issue is going on. So many different chief complaints can occur. So we can see there can be some variations: chest pain, shortness of breath, dizziness, altered mental status, palpitations, unconsciousness, indigestion. The list can go on, and they will vary, again, based on what the underlying cause or issues that are going on are. Mentation-wise, you should determine a baseline mentation if there's any abnormalities noted with the GCS or oriented questions. So sometimes the patient may appear restless, anxious, confused, maybe even a little lethargic at times as well, just depending on what's going on. Airway, For cardiac emergencies, airway should be unaffected unless the patient becomes unconscious, altered, or lethargic, vomiting develops, or respiratory or cardiac arrest develops. So most of the time, airway isn't going to have any issues unless those situations arise. With breathing, breathing will vary again based on the situation, but it wouldn't be abnormal to see patients who had labored rapid accelerated breathing, rate, or effort, which may or may not be present again, as well as an increase in respiratory effort. So they may be putting themselves in a sniffing position, they may be nasal flaring, they might be kind of tripoding themselves, stuff like that may occur. They may have no respiratory complaints, as we kind of discussed there in that previous portion. Lung sounds in most cases should be clear. Again, there might be breath sounds indicating other conditions present or other accompanying symptoms related to issues. So again, crackles or rales might be related to heart failure, or wheezing in patients without history may indicate cardiac involvement, or like a cardiac wheeze that sometimes may evolve it or be involved in patients. Circulation-wise, it's good to assess rate, rhythm, quality of pulses. Typically, this will, hemodynamically, or how their cardiovascular system is working, it should be stable. It should be unaffected. Rate may be elevated or decreased. Irregular rhythm may indicate possible of heart rhythm issues going on as well. So just keep those in mind. Quality may indicate if there's, kind of a lack in quality of a pulse or a weak pulse. It might just indicate blood pressure being affected. Assessing for skin color, temperature. Condition is another one. Again, very many variations in this. Patients may have red or pale skin, hot, cool, clammy, diaphoretic, typical shock stuff may be present in, patients who have an active event going on, like an AMI, pale, cool, diaphoretic, things like that, that'll vary. With patient priority and transport considerations, patients should be considered emergent if hemodynamically unstable. So we have issues with patients' blood pressure, issues with patients' heart rate, anything like that with the hemodynamics with their cardiovascular system. Instability in that, patients should be considered emergent patients. If there's any compromise of their ABCs is present, development of shock state, or presenting as symptomatic patient. So any of those situations, patients should be considered an emergent transport. Always consider requesting ALS. May be able to obtain further findings, with EKGs for situations, or provide further treatments. So medications, interventions, or treatments to the patient. So it's always good to request ALS and request ALS early if you feel you're going to need them. Transport patients to a cardiac or a cath lab capable facility. So the catheterization lab is where they'll do the cardiac catheterization, and they'll place stents in to clear some of those arteries that have been clogged or have some plaque buildup in them. So make sure to transfer them to those facilities if you have any suspicion of acute coronary syndrome or myocardial infarction present. Consider the need again for air ambulance if needed for definitive care, whether they're stable or unstable at time, with prolonged transport times present. So with these, types of cardiac incidents, patients may be stable at the time we see them, especially if you're a BLS unit and you don't have any ALS providers with you. Patients can decompensate at any time, with or without treatment. So it's good just to consider that, whatever the patient's presenting state is, make your best decision and kind of go from there. With indications for rapid transport, kind of similar to, determining if this is a priority patient, indications, would include the hemodynamic instability, signs of hypoperfusion or shock, no change in complaints with medications, significant EKG changes, advised per ALS or emergency department, which we'll discuss further. No transport indications. Typically, the only time we would not transport a patient is only if the patient refuses care or refuses against medical advice or AMA. There's no other indications. You would consider online medical control for advice for a symptomatic or alert patient who is refusing. So it's always good just to remember you need to make a phone call, talk to a doctor, at least to document that you did, or to get some more assistance, maybe to talk the patient into going to the hospital. History and assessment. History, again, obtain a good OPQRST sample history from these patients. It's good to ask clarifying questions a lot with cardiac patients, because the OPQRST is going to give you some basics, but the clarifying questions are really going to be the key in maybe determining a little bit more about this. So some questions, we can see a list of them here. Presence of activities at time of onset. So what were they doing at the onset? Location of complaints, area affected. History of similar issues in treatment diagnosis for past. So what has the patient done in the past, and how often are their symptoms occurring, or when is it occurring, or how long are the complaints occurring? If it's a recurring issue, has the patient talked with their primary care doctor about it, or had further blood tests or testing done to check on things along the lines with the cardiovascular system? If there's been any at-home treatment prior to our arrival, so if they've taken any NSAIDs, aspirin, nitro, maybe an inhaler or nebulizer, and if there's changing complaint with movement, activity, breathing, as well as medications improving or worsening over a period of time. So those are just a few clarifying questions. It's just clarifying some of what you ask with the OP or QST and sample as well, but it's just a good way to clarify some stuff and maybe dig into more what is causing the issues. Medication history, allergies, cardiovascular and respiratory medical history being most relevant in these situations. So, cardiovascular, you can see the long list of things here. They might have history of angina, an MI, coronary artery disease, or peripheral artery disease, arteriosclerosis, CHF, arrhythmias. The list can go on with that. If there's any of those kind of presence of history, it should just increase your index of suspicion as far as maybe this being cardiovascular related, especially with respiratory too, because respiratory can affect the cardiovascular system as well, with congestive heart failure kind of being a cardiovascular and respiratory related issue in some cases. Respiratory stuff, COPD, asthma, pneumonia, tuberculosis, respiratory infections or illnesses could all indicate maybe something spreading to the cardiovascular system, or maybe those exacerbation of symptoms affecting the cardiovascular system. Other stuff that might be pertinent: diabetes, stroke, cancer, any other chest pain imitators present. So if they have maybe the respiratory related issues, maybe they have, think about maybe a pneumothorax causing the chest pain. They could have some chest pain related to some abdominal related issues. Maybe this is indigestion related to, a flare up of maybe some indigestion from something they ate in their stomach, or maybe this is another issue going on with cholecystitis or maybe appendicitis, things like that. If there's any allergies, any pre-hospital medications or other medications, make sure to document those. Prescribed medications, this is another good one to ask with these situations, because again, any of the cardiovascular emergencies or cardiac emergencies we talked about, their symptoms could be due to them, being non-compliant with medications. So it's good to just ask about compliance with medications or any recent changes or additions to the medications. The list below is just some, pertinent medications they might be taking related to the cardiovascular system. So aspirin, nitro, blood thinners, beta blockers, ACE inhibitors, diuretics, and antidysrhythmic medications. Continuing our assessment history, it's good to double check your pertinent negatives or other symptoms or complaints the patient may be having. So syncope, loss of consciousness, dizziness, use of illicit drugs or alcohol, abdominal pain, indigestion, the whole list here, and even more so, just to make sure you're not missing anything. There could be a key symptom they're having that could indicate maybe something else is going on, or maybe you ask them a question about abdominal pain and they start to talk to you about maybe some other abdominal issues they've had, like talked about the cholecystitis, with the gallbladder and flare up. Maybe they have history of some appendicitis issues or had some appendix flare up, stuff like that. So it's good to just double check those and make sure that if there is any presence of other symptoms, maybe just dig into it a little bit more to see if it's pertinent or not pertinent to your assessment and your findings. With our assessment, always assess the chest for any external injuries or unstable structures present, scars from previous procedures, pacemakers, or automated implanted cardiac defibrillator devices, or AICDs. Assess the chest or areas of pain for tenderness or pain with palpation, always good. Presence of any peripheral edema indicating heart failure or fluid retention issues. So peripheral edema present within their legs. They normally get it in their pedal edema, what they call it, in their ankles and their feet. They can have this edema building up in their kind of lower back, their abdomen. They can get it in their hands and their arms. It kind of just builds up and pools in those areas. So just always good to double check those areas. And if there is any present, determining whether this is new or not. The chest pain tenderness with palpation could just indicate maybe can help you just determine maybe if there's some chest wall trauma, maybe if there's some chest pain from coughing. There's lots of different things like that can help indicate it. And then the presence of any, injuries or scars or anything like that can help us determine whether maybe there was chest wall trauma, maybe they have history of previous issues, things like that. Just helps us indicate and dive deeper into our assessment. Vital signs that we should be looking for on cardiac patients. Blood pressure can be high or low, again, just depending on what's going on or what's the issue exactly is. If you find a high or low blood pressure, it should increase your index of suspicion of cardiovascular involvement. Obtain bilateral blood pressures is needed, also to confirm any irregular initial findings. It's good to obtain bilaterals if you can, just to make sure that if there is some other underlying issues going on, like an abdominal aneurysm, things like that, where there might be some irregularities in your blood pressures present from that. Heart rate, rate and irregularity will depend again on underlying history and current complaints. So don't assume heart rate, rhythm, and quality are normal for the patient and it's not experiencing a cardiac event. So it's always good just to double check, look at your medications, because sometimes medications might play a factor in the heart rate. Sometimes recent history might have play a factor in the heart rate. So just monitor those and check them and never assume. Oxygen saturation, respiratory rate, lung sounds, index of suspicion should also increase if their SpO2 level is less than 94%. In patients with minimal to no cardiac respiratory history, that could just indicate some other underlying issues going on as well. It's always good to obtain other vital signs as well, capillary blood glucose, temperature to rule out any other issues or potential causes with the EKG, the electrocardiogram, the ECG. So this is something that will provide a visual reading of the heart's electrical rhythm. It does not represent the heart's physical ability or current contraction, because the heart can have electrical impulses without any mechanical contraction, and this is called pulseless electrical activity. If equipment has abilities to do it, sometimes you can take an EKG and transmit it to the receiving hospital, which can help a BLS unit provide better definitive care for patients. So in these situations, ER physicians, cardiologists can review an EKG to determine if there's any presence of maybe a myocardial ischemia, infarction, or irregularities with their heart rate or rhythm. So ultimately providing more informed care for a BLS unit if ALF providers or Intercept is not available. So this is something that we'll discuss a little bit later with EKGs and how EMTs can have the ability to do EKGs as well as potentially transmitting them to the receiving hospital. Like discussed in the previous slide, electrocardiograms or ECGs or EKGs, we can use these to help determine what the heart's electrical rhythm looks like. Now, as a BLS provider, you were able to place and obtain these readings if you have the correct equipment. However, you cannot interpret what the EKG rhythm is. So you can't determine what the rhythm is, if there's any irregularities with it, if it looks normal, if it doesn't look normal. You can just place the leads, obtain the reading, and print it out. So this is good purpose for providing the EKG for ALS providers, or if you can't get an ALS Intercept or don't have any ALS providers available, you can transmit it to the emergency department or provide it to the emergency department upon your arrival. So placement of the leads, as you can see, the ones that have the initials with the lettering, so RA, LA, RL, and LL, are all placement of the limb leads is what we call them, which could be a 3 or a 4 lead in some cases. 3 or 4 lead EKG is the correct term for it. As we can see, the RA is typically the white colored lead that'll go on the right arm. The RL is the right leg, and it'll go down on the right portion of the waist. You can also put it down by the ankle, and the right arm one can also go on the shoulder in some cases, or kind of by the wrist. Same thing with the other side. LA is typically the color black, and it goes on the left arm or kind of the left portion of the upper chest. And the LL is red, which is left leg, and that goes on the left portion of the waist or down on by the ankle, or like I said, on the you could also do LA or the left arm by the wrist or on the shoulder. Chest leads are given as V1 through V6, as you can see in the image here. Placement is going to be pretty much as a standardized placement. V1 and V2 are placed in the fourth intercostal space on each side of the sternum. So V1 goes on the right side, V2 goes on the left side. Then you would go ahead and place V4, which is in the fifth intercostal space in the mid-clavicular region, which is the mid-clavicle down. Then you would place V6, which is in the fifth intercostal space, mid-axillary, so within the axillary region, which would be the armpit region. And you would place V5 between V4 and V6, and you place V3 between V2 and V4. Sometimes V3 can also be placed down a little bit. In the image here, you can see it's kind of up at an angle. You can also place it directly horizontal to V4 in some cases if patients have excessive adipose tissue, or if it's a female patient, you don't want to place typically any of the leads over any breast tissue. So those are the kind of other options with it. But this is a great option, again, for BLS providers to obtain this, to give to ALS, or to provide for the emergency department. So with management of cardiac emergencies, the first one we discussed was chest pain. So this could be chest pain, typically angina, acute coronary syndrome, acute myocardial infarction is kind of what we're treating or we're suspecting in these cases. With these situations, we're going to assess our ABCs, obtain baseline vital signs, including the rest of those, CBG with capillary blood glucose, temperature, lung sounds. Perform a 12-lead EKG for ALS providers or for the emergency department. And again, this is a good option because it is best to attempt to EKG in the position or place where the patient is found, so there's no EKG abnormalities may be present. And sometimes the EKG abnormalities may subside with the pain. So the pain may be presenting with some myocardial ischemia, and once that pain subsides, the EKG changes may also change and may not be present anymore. So it's also potentially upon patient moving can change some of the EKG abnormalities. So that's what the ALS providers in the emergency department are looking for, is any irregularities in it. So we want to make sure we can obtain one where the patient was found and to make sure we get a nice clean printout for them. Providing the oxygen if there's any dyspnea present or an SpO2 level less than 94%. Is basic or EMT basic in some cases, or an emergency medical technician. You can administer 324 milligrams of aspirin PO or per oral, so we can give it orally. Typically it's 81 milligram chewable tablets, and they'll chew 4 of those up to get 324 milligrams. Depending on your protocols or what your agency says you can and can't do for that stuff, most emergency medical technicians can use nitroglycerin. However, it can be only when assisting a patient in administering their prescribed nitroglycerin. So patients who have nitro, you may assist them in taking it. Typically, they have the 0.4 milligram sublingual or under the tongue tablets that you give every 5 minutes. Basically, max dose of 3 total, which is a max of 1.2 milligrams. So it's always good to make sure you take a blood pressure before you administer it, and after every dose to make sure it's still a systolic blood pressure greater than 90 millimeters of mercury after every dose, because which we'll see further, which we'll do a review over, is nitro will decrease patients' blood pressure. If possible to, when you're transporting or on scene or whenever applicable or able to, if you have the abilities to do the 12 lead EKG, you can repeat what they call serial 12 leads or repeat 12 leads after all treatments for ALS providers in emergency department. Again, because we may have some irregularities present with their EKG, and when we provide these aspirin and these nitroglycerin, it might make those EKG changes subside and not be present anymore. So it's good to have the sequence of it so that they can see there was an irregularity present, or maybe there wasn't any irregularity present, and then just show our treatments and any changes in that EKG afterwards. When treating a hypertensive crisis, we're always again going to start with our ABCs and obtaining our baseline vital signs, including bilateral blood pressures, capillary blood glucose, GCS score, and temperature. Provide oxygen if their saturation levels are less than 94%. And it's always good to consider supplemental oxygen, even if their SpO2 does not indicate oxygen treatment, if we suspect any ischemia going on or hypoxia going on to the brain, whether the high increase in their blood pressures decreasing their blood flow to the brain. So keep that in mind. Assess for potential of stroke symptoms as well. So again, with hypertensive crisis, this may be due to a stroke currently going on or could potentially cause a stroke. So assess for those stroke symptoms. Perform a CSTAT, which is the Cincinnati Stroke Triage Assessment Tool, which we're going to be looking for any conjugate gaze of their eyes. So looking up and to the left, up and to the right, and they're fixed looking that way with both of their eyes. We're also looking for any arm drift with that, and then any inability to answer one of the two orientation questions inappropriately. So if they answer one of the two wrong, then that's going to be an indication with it. And if unable to follow one of the two commands that we give them as well. And looking for any other stroke symptoms, so slurred irregular speech, facial droop, unequal grip, unilateral deficits where they're not able to move one side or not move one side as much, any abnormal gait or any ability to walk, things along those lines. It's good to attempt to roll any other stroke imitators when we're doing this, or if we have a suspicion of it as well. So if there's any postictal state after a seizure or that kind of altered mental state after they have a seizure, we need to make sure to rule that out. If there's any hypoglycemia, so low blood sugar, check a blood sugar, and if there's any head trauma present. If a CSTAT and a stroke scale findings are positive, obtain the patient's time when he or she was last seen normal, and transport emergent to the nearest stroke capable facility. So advise the facility as early as possible of a stroke alert and the ETA of the unit. So again, hypertensive crisis, sometimes patients may be completely, may not even know that they're having a high blood pressure crisis going on, but they also may have some symptoms related to it. And then again, they may be having hypertension crisis related to an underlying, medical emergency like a stroke. So just keep that in mind. Transport the patient as soon as possible and consider ALS intercept due to time constraints with patient's condition. So what we mean by this is when patients are having strokes similar to an MI or myocardial infarction, we're trying to get them to the hospital as soon as we can so that they can get definitive treatment and hopefully reversal of their condition that is presenting at that time. So it's always good to get going as quick as you can to the hospital once you obtain what you need and get a good background as far as ruling in or ruling out anything on your patient. And continuing with hypertensive crisis, if these patients have severe stroke symptoms present with the hypertensive crisis, airway control may be needed. So have those airway devices ready, have suction ready, a bag valve mask, things along those lines in case airway patency is lost. So the patient may have vomiting, altered mental status, or unconscious state, or even some irregular respirations or apnea that can develop. If stroke assessment in the CSTAT are not indicating a stroke presence or are finding negative findings, transport the patient in position of comfort to the nearest facility. As you can see, apply direct pressure to the nose with gauze if nose bleeding is present, and make sure to keep pressure applied until nose bleeding subsides. So that might be one of the symptoms that can arise with the hypertensive crisis is the non-traumatic nosebleed. So just keep that in mind and control that as needed. With dysrhythmias, arrhythmias, for the EMT level, assess ABCs and obtain baseline vital signs, including those capillary blood glucose, lung sounds, temperature. Obtain an EKG for ALS providers to interpret if able to, again, and provide it for the emergency department. Provide oxygen as needed, as you can see here, if the SpO2 is less than 94, if there's dyspnea or signs of shock present. We talked about obtaining the EKG as well as performing a 12-lead EKG for ALS providers in the emergency department. If the patient's stable, transport to the nearest facility and consider an ALS intercept. So what we mean by stable is their blood pressures, they're good, their heart rate, it might be elevated or decreased, but they're not showing any signs of hemodynamic instability. So again, their blood pressure is good, their heart rate may be off, but they're still maintaining fine. They have no severe symptoms of altered mental status, inability to stand or walk, things like that. So if they're stable, they're able to move, get them transported to the hospital, or wait till you get an ALS unit to scene or an ALS intercept is needed. If a patient ever becomes unconscious with these situations, you need to make sure you immediately reassess your ABCs and provide the airway breathing assistance as needed. So in some situations, they may become unconscious and they may remain unconscious. So if a patient does, you should suspect that cardiac arrest may develop. So if a patient becomes pulseless and apneic, so no pulses and they're not breathing, and it is witnessed by EMS, so you should go ahead and begin CPR and immediately apply defibrillation pads. Once you apply those defibrillation pads with an AED, you should go ahead and let the AED analyze the rhythm. So you'll stop CPR, analyze the rhythm, and if the AED directs to, you provide defibrillation. You should continue on with your BLS CPR efforts after this, and go ahead and continue on establishing an airway and ventilating the patient with BVM at 15 to 25 liters per minute of oxygen. With heart failure, assess your ABCs, obtain baseline vital signs similar to your other situations. If SpO2 or their oxygen levels are less than 94%, provide them with some supplemental oxygen. Obtain the 12-lead EKG for ALS providers and emergency department to interpret if able to. And again, this may be a situation if this is some type of acute heart failure, you might want to do it. If this is maybe even an exacerbation of a chronic heart failure or congestive heart failure issue, you still might want to consider it if able to or if time allows. If moderate to severe dyspnea occurs and is present and no improvement with supplemental oxygen, with the EMT level, you can use CPAP. So you can apply CPAP and begin at typically a pressure of 2 to 5 centimeters of water up to a max of 10 centimeters of water for our pressures. If at any time the patient becomes lethargic, systolic blood pressure drops below 100, vomiting develops, or the patient becomes unconscious, you should immediately remove the CPAP suction as needed and provide ventilations with a BVM at 15 to 25 liters per minute. And transport to the nearest facility and consider ALS intercept as needed. So the point of the CPAP is that it's not only going to hopefully help push if there's fluid accumulation within the lungs, so the pulmonary edema, the CPAPs not only help push some of the oxygen through the fluid and help continue to oxygenate our bodies. We have that gas exchanging occur, so we're able to perfuse our body properly. It will also, if the heart failure is related to a hypertensive crisis, which is related to the cause of the pulmonary edema, potentially with heart failure, then we can help change some of the levels with the blood pressure and some of the other pressure levels within our vasculature system to help get some of that fluid out of the lungs and back into the pulmonary circulation. And lastly, with managing a cardiac arrest, so in this situation, we have an unconscious patient. We'll immediately walk up and check for breathing and central pulse presence. If they're both absent, we'll begin 2 minutes of CPR or 5 cycles of CPR, or CPR to ventilation ratio. We'll immediately apply defibrillation pads, and at the end of the 2 minutes with our AED, or our 5 cycles, we'll analyze the rhythm with the AED. We'll begin providing ventilation to our patient with a bag valve mask at 15 to 25 liters per minute. And just remember, our CPR to ventilation ratio is 30 compressions to 2 breaths. We'll establish an airway with an OPA or NPA or a supraglottic device as soon as possible, and we'll suction continuously as needed. Remember that once we place an advanced airway, our CPR to ventilation ratio does change. At this point, we'll provide continuous CPR, so we will not stop to give breaths, and we'll provide breaths through CPR, breath every 5 to 6 seconds. So typically the rate will range as follows: 10 to 12 breaths a minute with this. So that's kind of the rate we're going for. We'll apply end-tidal CO2 inline device with our advanced airway if we have one present with the supraglottic airway to help confirm the advanced airway placement. And throughout CPR efforts, we can confirm the tube placement by other means as well, which we should do in every situation. So checking our lung sounds, checking for chest rise and fall, making sure there's absence epigastric sounds present, and our end-tidal CO2 findings, again, so with our waveform capnography and our capnometry number present. Again, we'll analyze with the AED every 2 minutes or 5 cycles of CPR. And at those times, we'll go ahead and check for a central pulse present. So we'll check a carotid pulse or a femoral pulse to see if they're present. We'll place the SpO2 monitor on the patient and check for CBG and pulses at this time as well. Continue through our cardiac arrest, consider possible causes of the arrest with our H's and T's that you may or may not know at the EMT level, but just consider some potential causes. At any point as the patient regains pulses, or if it remains pulseless, we'll continue CPR. If the patient does regain pulses, at that time we'll obtain baseline vital signs and a 12-lead EKG for ALS providers in the emergency room. We'll establish an Advairway if not completed yet, and continue to provide artificial ventilations or assist with patients breathing with a BVM. We'll transport emergent to the nearest facility, or consider obtaining that ALS intercept if not done already, or if not, they're not on scene at that time. And if patient goes back into cardiac arrest, we'll do the same thing. We'll provide BLS and CPR efforts at that time. So now we went through the types of cardiac emergencies, management, assessment, and treatments. We can go ahead and talk a little bit about BLS pharmacology review. So we'll talk about the medications that we may be using for a cardiac emergency at the EMT level. First one being aspirins. We know that aspirin is an antiplatelet, and it's going to reduce platelet aggregation, meaning that it's going to help reduce platelets from sticking and binding together. Indications for aspirin include suspected cardiac chest pain. So anytime we suspect it's a cardiovascular related incident causing chest pain, we want to give some aspirin. Contraindications to this, however, include allergy to aspirin or NSAIDs, so a non-steroidal anti-inflammatory drugs. They have any history of bleeding disorders present, or like hemophilia. There's current gastrointestinal bleeding or ulcers, or suspected AAA, which is an abdominal aortic aneurysm. We do not want to give aspirin in those cases. Some side effects they may have typically are all minor, so they may have some tinnitus or the ringing in the ears, nausea, vomiting, maybe some indigestion as well. Our dosage for aspirin typically is going to be either we're using 324 milligrams of the per oral aspirin, so typically it's times 4 81 milligram chewable tablets, or we'll use typically one 325 milligram oral tablet of aspirin is the other option to give. With nitroglycerin, in most cases, this is an assisted medication, so it means that we can only assist the patient with it if it's a medication that is prescribed to them. The action of nitroglycerin is a vasodilator, so the point of this is that we have some type of ischemia to the coronary arteries or to the heart. If the blood vessels are constricted more and we give them this, it might cause the blood vessels to dilate and relax, which then it'll cause the vasodilation, which then might result in more blood flow or more oxygen getting to the heart to relieve the chest pain. Indications is similar as the aspirin suspected cardiac chest pain. We do not want to assist patients in taking their nitroglycerin when they have a systolic blood pressure less than 100 millimeters of mercury, and the presence of an inferior STEMI with right ventricular involvement, which is something that only ALS providers will be able to determine. This is not something an EMT will be able to determine, as well as the use of any Viagra or Levitra within 24 hours or Cialis within 48 hours. So those are types of sexual enhancement drugs that typically a male will use. So if they have any use of those or a systolic blood pressure less than 100, we do not want to give it. In the case of the type of heart attack or the inferior STEMI presence, again, that might be something that using your best judgment about administering nitroglycerin to these patients. So it doesn't hurt to give it, but just use your best judgment as far as either waiting for ALS to get there, or maybe if they had a bad reaction to the first dose they took, maybe don't give them another. Side effects. Adverse effects can include hypotension, headache, dizziness, blurred vision, flushing of skin. They may have syncope develop as well, so you got to be careful, because if you give them the nitro, it could drop their blood pressure very dramatically. That's another reason why sometimes it's good to have ALS close or on scene before giving it, because if they have a dramatic drop in their blood pressure, it could be potentially put them unconscious or could affect their hemodynamic stability. Dosage of nitro is typically 0.4 milligrams sublingual, or you have the spray nitro where you push a spray under their tongue. That would be the other option. Typically one spray is 0.4 milligrams as well. So we want to do a dosage of the pill or the spray under their tongue every 5 minutes, as long as that systolic blood pressure is greater than 100 millimeters of mercury. Max dose, again, is total of 3 total dosages. And again, make sure to recheck a blood pressure after each administration and before administering it to patients. And lastly, with oxygen. So oxygen's action is to increase the inspired amount of oxygen to the body, so ultimately increasing the amount of oxygen into the bloodstream that we can use. Indications can include hypoxemia, dyspnea, so difficulty breathing, major trauma, acute chest pain, carbon monoxide poisoning, and shock of any cause. Typically, there's no contraindications to oxygen. There may be some side effects as it can dry out your mucous membranes if it's not humidified, so it can dry out your nose and stuff like that. It might cause some irritation or discomfort. And you should never withhold oxygen from patients, including COPD patients who may be more susceptible to become dependent on oxygen if you administer it. Never withhold it. If a patient needs it, you should administer it. A variety of different ways we can administer oxygen. Nasal cannula, we typically provide it 2 to 6 liters per minute. Nebulizer treatments, we typically will give 6 to 8 liters per minute. A non-rebreather mask, we typically give 10 to 15 liters per minute. And a BVM, we typically give 12 to 15 liters per minute, as well as up to 25 liters per minute if applicable per your protocols or what your device is able to provide. With medication administration, we always need to remember that there's some things to consider. The patient rights for medication administration is a very important one. We need to remember that we have the right patient, which is referring to the right patient at the time, which is normally only an issue if there's multiple patients present. We have the right route of administration, so we're administering it the correct way to patient, whether that's orally, whether that's sublingually, whether we're injecting it intramuscularly or subcutaneously. We're administering at the right time for the right reason, so administering for right indication. So if we're administering aspirin, we're administering it for suspected cardiac chest pain, as well as at the correct time. This is more for redosing patients or confirming indication to administer. The right dose is making sure we're administering the right amount, so double checking the amount of the medication we have. So if we want to give 324 milligrams of aspirin, we're confirming that's what we have. If it's by 81 milligram tablets, we're confirming that we have 4 81 milligram tablets. For the right concentration, we want to make sure we have the right concentration of medication in the vial or bottle, just as stated above. So we want to administer the right amount, as well as confirm the right amount in the vial or bottle that we need to administer. Right documentation should always take place as well. So properly documenting medication administration, as well as the patient's response to the medication. And the patient has the right to refuse as well. So the patient does have the right to refuse a medication by EMS as long as they are ANO times 4. So they're alert and oriented times 4 and able to answer all your questions appropriately. Other things to consider with medication administration is CPAP. So continuous positive airway pressure. We did touch on that again with heart failure. Typically we'll use CPAP for patients who have dyspnea and COPD, asthma, and CHF pulmonary edema patients. So indications, again, we want to make sure that these patients are going to fit the mask seal. They have an awake and presenting state, and they have an open airway. Their systolic blood pressure is greater than 90 millimeters of mercury, and there's presence of moderate to severe respiratory distress or discomfort. Contraindications for it: if any of these are present, you need to stop using CPAP or do not consider using CPAP. So persistent vomiting, suspected pneumothorax, respiratory arrest, non-cooperative patients, if there's an inability to fit a mask seal, hypotension is present, or if there's head neck trauma present, we do not want to use it. With device placement, we need to remember that this is a very uncomfortable procedure to a lot of patients. So coaching the patient is very important through the whole procedure. We need to make sure that we monitor SpO2 throughout, as well as end tidal throughout if we're able to, and turn the device on and place it onto patient's face while placing the straps. We should never remove the device unless mental status decreases or respiratory distress develops, or any of the contraindications develop during our treatment. We should set the device to a starting amount of 2 to 5, typically 2 to 5 centimeters of H2O, depending on the device type. And then we should use a max of 10 centimeters of water H2O as our max amount we administer. So typically we start at 2 to 5, and we can administer up to 10 of that centimeters of H2O for the pressure. We should remember that there should be a max pressure of 5 centimeters of H2O in COPD or asthma patients as well. With heart disease and cardiac arrest and cardiac emergencies, we know that it's a very high prevalence in the United States. So one thing that we can do to prevent having cardiac emergencies or prevent having any of these situations arising is prevention and education. So many cardiac diseases and emergencies can be related to underlying health. So patients who may not take care of themselves the most healthiest way may be doing things as listed below. So there's ways that we can improve our cardiovascular related health, which can include maintaining a healthy diet and exercising regularly, quitting smoking or drinking alcohol, visiting a doctor regularly, managing other medical conditions that may be attributed to it, like our cholesterol, our blood glucose levels, our A1C. And if a family history of cardiovascular disease is present, it's good to talk to your doctor about ways to lower the risk and monitor for symptoms of cardiovascular related issues. So as we can see in the image on the right, there's other things we can kind of monitor, keep an eye on, that can help decrease our risk throughout our lives. With special patient populations, pediatrics typically develop cardiovascular related issues at birth or while they're developing. So we call this a congenital heart disease or congenital birth defect. Typically, these defects can include a septal chamber defect within their heart, valvular issues, as well as vasculature issues. Typically, though, cardiovascular compromise in pediatrics is actually caused by respiratory compromise. So typically a respiratory arrest or respiratory related issue ends up causing cardiac arrest in the end. So that's the most common cause. Adolescents may be more prone to start developing medical issues with activities or lifestyle. So patients who may develop asthma with sports or exercise, they may develop rapid heart rates with sports or energy drink consumption. Diabetes, type 1 or prediabetes may begin to develop, as well as congenital issues becoming more of issues as they get throughout their childhood and throughout their lives. Patients, parents, caregivers may be able to provide helpful information on patient's history, as well as any treatments advised by the patient's primary care physician. So the patient or caregiver may also be an expert on the patient's underlying issues. If it's not something that we run into on a frequent basis, or it's a more of a rare condition, they may be the ones to provide some information for you as far as what is the condition going on. With geriatrics, cardiovascular emergencies in elderly patients may have symptoms related to other disease processes, as well as medical history that increases the likelihood of cardiovascular issues. So they may have just symptoms of increased shortness of breath, although they have a history of COPD, asthma, or CHF. They may have increased weakness, fatigue from baseline, diabetes. They may have a history of blood clots, stroke, hypertension, things along those lines. They may or may not have underlying health issues actually related to cardiovascular system. As you get older, things start to develop over time, and this may be a new related event that is occurring. So they may have no history of cardiovascular related issues, or maybe just some hypertension. As they get older, our bodies start to get a little bit older. We start to get maybe plaque development over time, and then they might start developing, the acute myocardial infarction after, years and years of life, and they may have no other history of it. So this could be a new issue. Chances of our cardiovascular emergencies do increase with age, just as discussed earlier. Our bodies go ahead and start to deteriorate. We're not able to do the things we used to. We're not able to compensate for certain things anymore. So we can have some of those issues arising. Elderly can have worsen in symptoms or potential irregular symptoms as well. So due to underlying history, degenerative loss of pain, nerve sensation, symptoms can be covered up by prescribed medications as well. So just keep those in mind. And patients may have history of similar issues and may be able to provide similarities from past issues. So it's good to ask if they have had issues in the past, and if so, what did they do for them, and what was the treatment as far as to get their symptoms or their issues to resolve from what either the hospital did, what they did, or what maybe a physician or a doctor advised them. In summary, for cardiac emergencies, cardiovascular health is becoming one of the highest concerns for the United States, and it is a very dangerous health issue if heart disease does develop for patients or other issues along those lines. Many cardiovascular related issues can be prevented or made less likely with proper diet, exercise, and management of underlying issues as well. Chest pain should always be suspected to have cardiovascular involvement unless proven otherwise, and even in those situations you should still have a suspicion of it. Vital signs have a chance of being normal or only slightly off, even with life-threatening emergency present. So always have a high index of suspicion. And if patients are symptomatic with altered mental status, irregular vital signs, or hemodynamic stability, be prepared for patient to deteriorate rapidly and be aware of the situation. Understand the importance of the EKG with cardiac emergencies and how BLS providers can obtain these findings to provide readings for higher level of care as well. And always have ALS units en route to calls or consider need for ALS intercept in symptomatic patients. Thank you for joining us again for today's lecture. We hope to see you next time.
Now let's transition into some multiple choice questions.
Question number 1. The heart contains blank separate chambers. A2, B4, C6, or D8. The correct answer is B4. The heart is divided into 4 chambers, which include the right and left ventricles, as well as the right and left atrium. Question number 2. What role does the superior vena cava play in regards to blood flow through the heart? A. Drains blood from the lower body into the heart. B. Carries blood from the left ventricle to the rest of the body. C. Takes blood from the lungs to the left atria. Or D. Drains blood from the upper body into the heart. The correct answer is D. Drains blood from the upper body into the heart. The superior vena cava brings deoxygenated blood from the upper portions of the body to the right atrium. Question number 3. The heart wall is made up of all the following layers except A. Pericardium, B. Endocardium, C. Myocardium, or D. Visceral layer. The correct answer is A. Pericardium. The pericardium is a layer around the heart and does not comprise a part of the heart wall itself. Question number 4. How do you calculate cardiac output? A. Blood pressure multiplied by heart rate. B. Heart rate multiplied by respiratory rate. C. Stroke volume multiplied by heart rate. Or D. Stroke volume multiplied by lung capacity. The correct answer is C. Stroke volume multiplied by heart rate. The cardiac output is the amount of blood your heart pumps out in 1 minute. Stroke volume is the amount of blood that is pumped out to the body with every beat. And to calculate cardiac output, you need to multiply the amount of blood pumped out during each beat and multiply this by the heart rate. Question number 5. You have just administered your first 0.4 milligram nitroglycerin sublingually to a 44-year-old female experiencing acute chest pain. How long should you wait before checking a blood pressure to see the effects of your drug intervention? A. 3 to 5 minutes. B. 7 to 10 minutes. C. 10 to 30 seconds. Or D. 15 to 30 minutes. The correct answer is 3 to 5 minutes. The onset of action for nitroglycerin is roughly anywhere from 1 to 5 minutes, though it may peak closer to 5 to 10 minutes depending on the patient. You should check a blood pressure before as well as after administering nitroglycerin to any patient. Question number 6. What is the correct dosage range for administration of an epinephrine drip? A. 2 to 10 micrograms per kilogram per minute. B. 2 to 10 milligrams per kilogram per minute. C. 20 to 50 micrograms per minute. Or D. 2 to 10 micrograms per minute. The correct answer is D. 2 to 10 micrograms per minute. Epidrips range from anywhere from 2 to 10 micrograms per minute. You can set one up by placing 8 milligrams of epinephrine 1 to 1,000 in a 1 liter normal saline bag. Question number 7. Which intervention is recommended for regular, monomorphic, wide, or narrow tachycardias with a pulse? A. Atropine 0.5 milligrams. B. Amiodarone 300 milligrams. C. Adenosine 6 milligrams. Or D. Epinephrine 1 milligram of 1 to 10,000. The correct answer is C. Adenosine 6 milligrams. Adenosine is an acceptable intervention as it can help slow the heart rate down to allow for the paramedic to analyze as well as interpret the rhythm more accurately. Question number 8. You are called to an apartment building where a 60-year-old male complains of chest pain. You conduct a thorough assessment and sample history. You learn that chest pain started while the patient was moving large boxes from his bedroom to a moving truck parked outside. The pain subsided about 5 minutes after he had sat down, and he described the pain as a crushing pain. This patient is most likely experiencing which of the following? A. An acute myocardial infarction. B. Angina pectoris. C. Congestive heart failure. Or D. A cardiac dysrhythmia. The correct answer is B. Angina pectoris. There is nothing in this question to suggest that the patient is experiencing congestive heart failure or cardiac dysrhythmia. There are 3 main differences between chest pain due to angina and myocardial infarction. First, angina usually occurs following exertion or emotional stress. Second, angina typically lasts between 3 to 8 minutes. And lastly, angina is usually resolved by rest and/or the administration of nitroglycerin. Patients with angina will often describe the pain as well as a crushing sensation in their chest. Question 9. Which of the following refers to a drop in blood pressure associated with prolonged standing? A. Neutrally mediated hypotension. B. Hemostatic hypotension. C. Postural hypotension. Or D. Orthostatic hypotension. The correct answer is A, neutrally mediated hypotension. This is a condition that is caused by faulty brain signals, which can happen after a patient has stanned for prolonged periods of time. It is more common in children and young adults, and it is believed that the drop in blood pressure occurs due to a miscommunication between the heart and the brain. Last question, number 10. You arrive on scene of a 53-year-old female with chest pain. She reports a sudden onset of shortness of breath while doing some yard work with her husband. She tells you it quickly progressed to chest pain, nausea, and significant malaise, which nearly resulted in a syncopal event. She appears to be diaphoretic on assessment, and her medical history includes angina pectoris and hypertension, though she denies any history of this symptom progression. You obtain vital signs as follows: blood pressure of 80/60, heart rate of 60 and regular, respiratory rate of 24 is shallow, SpO2 reading of 95% on room air. Her capillary blood glucose is 91 milligrams per deciliter, and her temperature is afebrile. Upon examination of the EKG and 12-lead EKG, you note a sinus rhythm, although in leads 2, 3, and AVF have ST elevation, and leads 1 and AVL have ST depression. Based on this information, what is the most likely cause of this patient's hypotension? A, hypovolemia. B, right ventricular involvement. C, a pulmonary embolism. Or D, a lateral myocardial infarction. The correct answer for this question is B, right ventricular involvement. Inferior STEMIs, or ST elevation myocardial infarction, often cause reduced preload due to right ventricular failure. When the right ventricle lacks oxygen, its ability to pump enough blood to the left ventricle is compromised. Ultimately, this reduces systemic blood volume, causing hypotension. This patient presents with symptoms of RVI, or right ventricular involvement, which can be confirmed with a V4R on a 12-lead EKG, which views the right side of the patient's heart. Greater than 1 millimeter of ST elevation in V4R indicates the potential of right ventricular involvement. Right ventricular involvement is also associated in some cases of inferior STEMIs.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.